Hi, welcome to Guideline Updates from MedStudy. I'm Dr. Paul Catalana, and referenced at the bottom of your screen is a recent article from Pediatrics that provided an update in regard to the evaluation and treatment of children and adolescents with eating disorders. And in order to briefly review the highlights of this particular article, let's start with some of the changes in definition. First, anorexia nervosa in the DSM-5 criteria no longer includes amenorrhea, nor does it include the use of specific weight percentiles. In regards to bulimia nervosa, the most important change is a decrease in the frequency of binge and purging episodes. And by definition, an individual meets criteria for bulimia nervosa if that individual has at least one binging and purging episode per week during the previous 3 months. So now one or more. Other changes include the following. The term eating disorder not otherwise specified has been dropped and replaced by the term other specified feeding eating disorder. And as the name implies, these are individuals with disordered eating that do not, however, meet DSM-5 criteria. Newer categories of eating disorder include the following. Binge eating disorder. And as the name implies, it shares a lot of similarities with bulimia nervosa, with one very important exception. And that is individuals with binge eating disorder do not practice purging behavior. So these individuals do not practice self-induced vomiting, nor do they use compensatory behaviors such as laxative use or diuretic use. In addition, avoidant, restrictive food eating disorder now includes not only young children and infants, but also older children and adolescents. And in this particular disorder, the individual is not concerned about body image or current weight, but on the other hand, is, for example, very fearful of eating because of a perceived possible adverse consequence, such as vomiting or choking. In younger children, this disorder may be due to the fact that the child has an oral aversion to certain textures or consistency of food. And then again, avoidant, restrictive food eating disorder may be seen in individuals who simply have no interest in eating whatsoever. Finally, remember that the female athletic triad has been replaced by the term relative energy deficiency in sport. And one of the reasons for this change is the recognition that eating disorders are far more common in males than was once originally thought. So in individuals with relative energy deficiency in sport, certainly for those who are female, amenorrhea may be a component of their signs and symptoms. But for both males and females, there may be a history of stress fractures or decreased energy associated with decreased exercise tolerance and decreased performance during the particular sporting event. So these updated changes and definitions are important to keep in mind as you evaluate patients. Now, in regards to prevalence and epidemiology, the most recent data suggests that about 0.3% of individuals are impacted by anorexia nervosa, about 0.9% by bulimia nervosa, and anywhere from 1.6 to up to 4% impacted by binge eating disorder, making binge eating disorder the most common type of eating disorder. And another 2 to 2.5% of individuals have disordered eating that do not yet fit into a particular DSM-5 criteria. Also, what was once thought to be a disorder typically in young, non-Hispanic, white, affluent females is now recognized to occur in males and in females, also occurs in individuals from all racial and ethnic backgrounds and from all socioeconomic groups. And then finally, eating disorders occur more commonly among sexual minority youth. A detailed review of systems is critical, as is a detailed physical exam, in order not just to take care of these individuals on an outpatient basis, but also in terms of making a decision in regards to which individuals need to be hospitalized. So following a review of systems, which should include a typical HEADS assessment in all adolescents, the mnemonic stands for home, education, activities, drugs, sexual practices, and suicidality, especially with the latter. If there is concern about suicidality or other significant comorbid psychiatric disorder, that should prompt hospitalization. Finally, what else should prompt hospitalization? Take a careful look at vital signs. If hypothermia is present, defined as 96 degrees Fahrenheit or less, that individual should be hospitalized. Also, those with a BMI of less than 75% of expected should be hospitalized. And in regards to cardiac findings, be sure to hospitalize individuals with bradycardia, defined as a heart rate of below 50 while awake or below 45 while asleep, or other ECG abnormalities in addition to bradycardia, such as a U wave or a prolonged QT segment or other arrhythmia. Also, in regards to blood pressure, hospitalize an individual with a blood pressure less than 90/60, or in individuals with specific orthostatic changes, including an increase in heart rate of over 20 beats per minute, or a change in blood pressure during orthostatic blood pressure measurements of more than 20 millimeters of mercury in regards to systolic blood pressure, or a change of more than 10 millimeters of mercury for diastolic blood pressure. Other reasons to hospitalize an individual include acute medical problems, again, such as syncope, cardiac arrhythmias, superior mesenteric artery syndrome causing duodenal obstruction, pericarditis, syncope, seizures. And any of these, in addition to, as I mentioned earlier, comorbid psychiatric disorders, should prompt hospitalization. So to summarize, keep in mind the changes in definition of eating disorders, the addition of other categories of eating disorders, the changes in the prevalence of eating disorders to include many more individuals from different backgrounds than was originally thought. And then finally, an emphasis on the mental health well-being as well as the physical well-being of the individual, and then consider hospitalization versus intensive outpatient treatment for those individuals. So take a look at this article. It's a great review and will hopefully help all of us take better care of individuals with such a challenging diagnosis. Thanks again for joining Guideline Updates from MedStudy.